Everyone, welcome to researchmd.com. We got a great presentation today. We're going to teach you all about the headache, which is migraine headache, right? A headache is very, very common disease. So again, our purpose is to teach you everything in 9 minutes. That's it. That's all the time we have to teach you. We understand how important is your time, but make sure you repeatedly watch this. So the more you watch, the repetition is the key, my friend, right? No point in watching like 1 hour, 2 hour video and you cannot repeat it or repeatedly watch it, it will not hold into your brain. Okay, remember that. So when we talk about migraine, my name is Pramil, Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents, and I'm a director of research. Let's get into our subject. So what is migraine? Definition: it's a sensory processing disturbance with a wide ramification in the central nervous system. While pain is used as an exemplar symptom, it's a brain-centered explanation, provide a framework to understand all the manifestation of migraine. Okay, so it's a sensory symptom. People feel like severe headache pretty much in the migraine, right? And familiar or not, there's a lot of studies kind of look at, is it a relation, is it like a family, can it come from family? So is it familiar? There's like a lot of information coming out. Inheritance account for like 40% of the migraine susceptibility. Okay, remember that. So there is a family component. Your family members have migraine, most likely you could have migraine too. And the common epidemiology, if you look at it, 12 to 15% of the general population, huge number of people affected. Women, more common. So, and the migraine without aura is like 75% of the case, and more common in the age 30 to 39. Migraine is a major cause of disability after the low back pain. So the important to the society, and the amount of work days lost is huge when you talk about epidemiology. If you look at the pathophysiology, it's kind of very, very important to know. There's there's 4 phases of the premonitory symptom. There's like aura, headache, and the post-dromal symptoms, right? One of the most common thing is the vascular theory of the migraine. What will happen? You have vasodilatation of the migraine, and then you feel the pain in the vessels in the brain, okay? And then you got the cortical spreading depression. What is that? It's a self-propagating wave of neuronal and glial depolarization that spread across the cerebral cortex, okay? So there's a causal association between migraine aura and headache is both by cortical spreading depression. So it's the cause of migraine with the aura. Remember that. Cortical spreading depression. Okay, then migraine without aura, first you got activation of trigeminal efferents by the cortical spreading depression, central and peripheral reflex mechanism, opening of your neuronal pannexidine mega channels, and there's subsequent activation of the capsosase 1, and then you got release of the pro-inflammatory mediators are there, and prolonged activation of the trigeminal nociception there, and that's what the causes the migraine without aura. Then we talk about it's also involvement in the trigeminal system is also very common. Activation of the trigeminal system, which is a small caliber pseudo-unipolar sensory neuron that originate from the trigeminal ganglion in the upper cervical roots, and they project and innervate the large cerebral vessels, venous sinuses, and the meninges. And this arterial structures are innervated by the ophthalmic division of the trigeminal nerve, and there is this posterior structure innervated by the upper cervical nerves, and nerves from the upper cervical nerve roots and the trigeminal nerve root also converge on the trigeminal nucleus, and the distribution of the migraine pain is the anterior and the posterior regions of the head and the upper back is kind of noted. So from the trigeminal nucleus, fibers kind of ascend to thalamus, and then subcortical sites, and then more rostral brainstem nuclei. There's like nociceptive information transmitted into the other brain areas like limbic region, okay? So this neurogenic inflammation is thought to be the important in the prolongation and the intensification of this headache in the pain and sensification. So trigeminal pathway play very important. So what is the diagnostic criteria? That's what we need to know. How does the International Classification of Headache Disorders? What's the criteria? repeated episode headache, 4 to 72 hours, okay? Any two of the following: unilateral throbbing, worsened by movement, moderate or severe, or anyone like nausea, vomiting, or photophobia or phonophobia should be there. So those are the criteria by International Classification of Headache Disorder. But in order to diagnose this, we're going to teach you all about this mnemonic called a pound criteria. Very, very important. Pulsatile quality, 1 day duration, unilateral location, nausea, vomiting, disabling intensity in the primary care. So if you have this pound criteria, if they meet 4 to 5, likelihood ratio 24, that means your risk is like almost like 60-70% high, very high risk, okay? So use the pound mnemonic to diagnose it. Then you have the phase of the migraine, there's the prodrome syndromes, right? 1 or 2 days before you can have like subtle changes, some warning saying, constipation, mood changes, depression, euphoria, craving, neck stiffness, and all of this. And then you got aura. What are the aura? It's reversible symptoms of the nervous system. Usually like kind of visual, can also include other substance, other disturbance, like each symptom usually begins gradually, build up over several minutes, and can last up to like 60 minutes, okay? You can see various shape. There's going to be blind spot, flashes of light, and then you got migraine headache, which is lasts from 4 to 72 hours. Then you have the postdrome. What is the postdrome? You got the spontaneous throbbing of the headache results, all from the vasodilatation of the vessels. Now, when you look at the precipitating, several precipitating characters are one: stress, flickering lights, visual. That's why some of the people stay in a dark room, and the hormones in women, not eating, weather, sleep disturbance, alcohol, specific food, aspartame, and smoking, odors, and chocolate mainly, like exercise. All of this can stimulate. Several things can be. And then migraine subtypes, there's you got recurrent painful ophthalmoplegic neuropathy, migraine with the brainstem aura, there's like hemiplegic migraine, all several subtypes, retinal migraine, vestibular migraine, menstrual migraine, chronic migraine. What are the complications of migraine? You can have a status migraine, that debilitating migraine that can last more than 72 hours, okay? You can have persistent aura without infarction, without an infarction. Then you got migraneous infarction. Then you have a neuroimaging, you will say an infarction in the relevant area. And there's migraine aura triggered seizure. Those are like bad complications of migraine. So investigation or indication for further workup, always look for the red flag. If there is red flag, you know the red flags are the pain wake the patient up at night, age greater than 50, associated with any focal deficit, fever, neck pain, history of malignancy, all of that. In that cases, you can do CT, MRI, and all that, okay? Indication of the preventive therapy, like attack significantly interfere with the patient daily routine, and then you have to do it. Frequent attack greater than 4 per month. Contraindication to failure or overuse of acute treatment. And hemiplegic migraine, you have to do the preventive therapies, right? What are the preventive? Like 10 more days a month, though, you can for like ergo derivative, tripsan, opioids, and combination of analgesics. If it is 15 or more per month, for like non-opioid analgesic, acetaminophen, NSAID, and all that. Preventive care, we talk about beta blocker has a role, propranolol, metoprolol, calcium channel blocker, tricyclic antidepressant, valproate, topiramate, Botox injections, the new therapy for that. Lifestyle modification, very, very important. Dietary management, exercise, sleep hygiene, all of this will help you to decrease. So in acute attack, you can use aspirin, and then ibuprofen, acetaminophen, naproxen, diclofenac. And the moderate to severe migraine, you can use the triptan, sumatriptan, and give metoclopramide or like prochlorperazine if there is associated with the nausea, vomiting. Just remember this table like clearly what the medications, okay? So thank you so much for watching. We'll be back with another presentation. Remember, the pound mnemonic is very, very important diagnosis. Thank you.